Okay, folks, let's get started. Before we get started, let me go ahead and make a quick announcement. I am planning to postpone your first lecture exam 1 week back. So your exam is going to be February 25th. Okay? But I will send everybody a notice and announcement on the Blackboard as well. Just be aware of. I think the syllabus is at 18. Which is going to be next week. We're going to push it 1 week back because we haven't covered everything that I want to cover. Any questions before we get started?
It's still going to be chapters 1, 6, 7, 8, 9, 10, 11, 16, and 18.
What's that?
It's still going to cover 1, 6, 7, 8,
Well,
9,
we got come on, what is that? What kind of questions that? We haven't got to it next week. I don't know how far I'm going to go next week. I'm going to cover 3 chapters this week today. So don't be surprised because we're going to cover lecture 3, 4, and 5 today. So if we be able to cover the next 3 lectures next time, then that would be it. Yeah. The key is not. The key is what we covered in the class. The key is not. That's why we put the word tentative on the syllabus. Okay? Pay attention to that. Tentative means that we do our best. But again, we're going to see how far we're going to go. All right. Other questions? All right, let's get started then. What we are going to talk about today is going to be hematopoiesis. Hematopoiesis refers to the concept of production of blood cells. All blood cells. Because as you're going to learn today, all blood cells are coming from an original progenitor cell. Okay? We call that hematopoietic stem cell. Has the ability to become different cells depending on different cues in the environment. That's where we're going to go ahead and get our talk started. So there are different aspects of it. We are going to talk about where hematopoiesis is going to occur. We're going to have different stages. You're going to have embryonic stage. What is embryonic stage? What do we refer to as embryonic stage when we are talking about? How many days after conception we are going to consider embryonic stage? About 2 months, okay? The first 2 months is going to be more of embryonic stage. After 2 months, up to 9 months is going to be the fetal stage. And when the birth is going to happen, you're going to come into the picture, that's going to be its own stage, which is going to be divided into, childhood, infant, newborn, childhood, adulthood, adolescence, and all those different things. We're going to talk about these things today. The first is going to start post-conception, sometimes around 19-day post-conception. So the sperm and the egg are going to fertilize each other. Around 19 days after that, when the embryo has been planted into the uterus, you are going to have the yolk sac, amniotic sac, which the first hematopoietic activity is going to be able to be seen there. Red blood cells are going to be coming into pictures. We are not having any white blood cells. We are not having any platelets. Okay? It's going to happen post-conception, about around 19 days. It's going to happen in the yolk sac of the fetus, in the amniotic sac. The second phase is going to be a little bit more complicated. It's going to be the hepatic phase. So this is going to be the embryo. You're going to be able to see the yolk sac, amniotic sac. This is the place that you're going to have the primitive erythroblasts. Primitive erythroblasts. We will discuss this in greater detail when we come to it, that at each stage, you are going to have different type of hemoglobin molecules. See, there are going to be 2 genes, there are 2 groups of genes on 2 different chromosomes. Number 11 and number 16. These 2 chromosomes are going to have 2 regions that are associated with hemoglobin molecules. So you're not going to have just one type of hemoglobin molecules throughout your entire life. When you are going to be in this stage, you're going to start producing the red blood cells after the 19th day. You are going to have hemoglobin molecules, but those hemoglobin molecules are going to be slightly different than the one that you are going to have in your body right now. They have different names, but I'm going to not get into too much detail because I'm going to go ahead and allocate a specific time just to discuss it in greater detail. But there are different names: Portland, GAR1, GAR2. Then it's going to become fetal hemoglobin. Then it's going to become hemoglobin A, which is going to be alpha and beta hemoglobin. We're going to discuss the details of it. But that's going to be a different type of hemoglobin. Be aware of that. The hemoglobin is not going to be the same because there are different necessities for the hemoglobin to be able to do its job. Now I brought it up. Let me just go ahead and quickly tell you so you start thinking about it. When you are in a uterus of the mother, when you're an embryo, when you are a fetus, what's going to happen here is that you are going to have a hemoglobin. But do you think, where does the fetus get the oxygen from? From the mother. So what is going to instigate oxygen to separate from the hemoglobin of the mother at the placenta in order to come and bind to the hemoglobin of the fetus? See, that's going to cause a problem. You want a specific type of hemoglobin here in the fetus that is going to have more attraction to the oxygen, so the oxygen separates from the mother's hemoglobin and come and bind to the fetuses. That's the key. So these hemoglobins are going to be able to do different things. Keep that in your mind because we're going to come back and talk about it in greater detail. The second age is going to be the fetal age. The fetal age is going to become, most robust around the 3rd month post-conception. And it's going to continue, not at the highest level, but it's going to continue about a week or 2 after birth. Then it's going to basically go to dormant and it's going to shut down, but is going to maintain the ability of coming back if there's a need. Okay? If there's a need, it's going to be able to come back. But around 3 months, it's going to peak and it's going to gradually come down, and by the 1 week or 2 weeks after birth, it's going to stop down and it's going to allocate the function to medullary phase. Medullary phase, which is going to be in the bone marrow. Okay? It is at this time, during the hepatic age, that you are seeing the first signs of white blood cells. You see the first signs of platelets. So before that, you would not be able to see it. Now you are seeing that during the hepatic age. That's, hematopoietic phase. You are going to be able to see the white blood cells and platelets coming into the picture. And around 6 months, 7 months, what's going to happen here is that you will see a sharp rise in hematopoietic activity in the bone marrow. Now, where is bone marrow? When you think about the bone marrow, when you're talking about the fetus's bone is going to be what before it becomes bone? It's not going to be developed as a bone. It's going to be cartilage, okay? As the cartilage is being, converted into bones, what's going to happen here is that in all bones, the center part, so you're going to have the compact bone on the cortical region. On the medullary space, what you are going to start to have is that you are starting developing bone marrow cavities. So you're going to have cavities inside of the bone. And it's going to start hematopoietic activity inside those cavities. Medullary phase refers to the medulla cortex of the bones. That's where you're going to start the hematopoietic activity. When you are talking about the young individual, young newborn, 1 year old, 2 year old kid, about 100% of medulla of all bones are going to be doing hematopoiesis. Somebody who's growing, they have to go ahead and produce a lot of cells. Let me just put things in perspective so you understand what we're talking about in here. I want you to take a guess. How many cells in your bone marrow are produced per second? Per second. 1, 2, 3, that's 3 seconds. How many cells did you produce in 3 seconds? You produce 1 million cells per second. In 3 seconds, you produce 3 million. You got to get rid of the 3 million in order to go and allow this new 3 million coming, but that's going to be another discussion. So it is a very robust activity in a young individual, 100% of the medulla of the bones, it doesn't matter what the bone is. It doesn't matter, are we talking about the femur and the tibia? It doesn't matter if you're talking about the skull or the scapula. All the bones are going to be actively making hematopoietic cells. Now, there are important facts that you need to learn. The same way that I told you about, for example, reticulocytes is the new red blood cells number or percentage is a very important number in order to determine what is the problem with patients with anemia. Same thing is going to be another important number ratio that you need to know. You need to know these things. I don't consider this memorization. I consider this a tool that allows you to determine what's the matter with the patient. And that's going to be myeloid to erythroid cell hematopoietic cell ratio. So when we are talking about myeloid, primarily we are talking about this family. Neutrophils. I brought myself gloves. I don't respond. I break out when I use chalk, so I brought myself gloves. So I might take now. Okay. We are talking about neutrophils. We are talking about eosinophils. We are talking about basophils. And we are talking about monocytes. We don't talk about lymphoid cells, lymphocytes in this group. There is a ratio of myeloid to erythroid cells. Erythroid cells are going to be the cells that are going to become red blood cells. That's it. Okay? Myeloid are going to be these white blood cells. There is a ratio of 3 to 1. This is an important ratio. Okay? If you have lost large amount of the blood, if you got gunshot wound and you lost a lot of blood, and then I go in and do a bone marrow on you about 3 weeks after you are recovering in the hospital, you got to see that this range is different. What is the pattern is going to be? What the pattern is going to be? How is it going to be different? This ratio. You're going to have more of erythrocyte progenitors because you are trying to recuperate what you have lost. Therefore, you have to increase the production. How you want to be able to do it? You got to increase the erythroid. So it modulates in order to maintain everything with the homeostatic range. But this ratio of 3 to 1 is a good, important information. Remember that, okay? Remember that ratio because it's going to come back to you, especially when we are talking about leukemias. As we get older, what's going to happen here is that I don't know how much you remember about your anatomy and physiology. You got the bones in the center part of your body, which is going to be your skull, it's going to be your ribs, it's going to be your sternum, it's going to be your scapula, it's going to be your pelvic bones. We call those axial skeleton. And the bones in the arm and the legs are going to be called what? Appendicular skeleton. In a young individual, all bones are going to have hematopoietic activity. As we get older, things are going to go south. The way that everything else is when you get older. What happens is that your axial skeleton stops producing, having hematopoietic activity. In somebody like my age, if you have any kind of hematopoietic activity, is going to be found only in the femur, and not every place in the femur, only on the proximal side, the one that's closer to my pelvis, you will be able to find some hematopoietic activity. It's important because some of you might be able to work in a bone marrow laboratory. Some of you might have to go in and draw bone marrows. And it's not as scary as you think it might be. It's something that you can do it, and it's a specialized thing. You would be able to get a good training, something that not everybody is going to be aware of, how to be able to do it. So it's something that don't be afraid of it. But the bottom line is that what's going to happen in an adult, you're not going to have bone marrow everywhere, so you got to know where you're sticking your needle. You're just not going to be able to find the bone and stick it in there and try to get the bone marrow. In the younger individuals, it's much easier. As people get older, you got to know where you're going to stick, and we're going to go ahead and talk about this in the next lecture. As we are getting older, this marrow that is responsible for the production of blood cells, we call it red marrow, is going to be gradually replaced by the yellow marrow. Yellow marrow is going to be adipocytes. They are going to be the fat cells. And these fat cells have different functions. Some of these fat cells produce hormones in order to make sure that the other cells are doing what they're supposed to do. They're going to be a storage. They're going to be able to maintain the lipids that are going to be needed. So they're not a bad thing. However, the yellow marrow is not going to have hematopoietic activity. You're only going to have the hematopoietic activity in the red marrow. As we get older, yellow marrow increases, red marrow decreases. Okay? So this is basically the graph that's going to indicate the different stages, different phases of hematopoiesis. You are going to start in the yolk sac, but yolk sac is going to start declining quickly. Within a month or two, it's going to go down, which is going to be replaced by the hepatic phase. And you can see that it should make sense, but it's good to pay attention to these things. You don't have off and on switching here. You're always going to have a gradual thing. It's not that yolk sac stops, then the other one is going to start. See, there's an overlap. There's an overlap because you don't want to leave the body defenseless and in limbo. You want to make sure that somebody else is going to be replacing what you are trying to shut down. So everything is going to happen gradual. And that's going to be the key about the homeostasis. It doesn't happen immediately. It's gradual. Okay? So you can see other places based on the age on this side. You would be able to see the places that you would be able to obtain bone marrow from adults as they are getting older. But there is another lecture next that we're going to discuss that in greater detail. Okay. Hematopoietic tissue. So we are going to have different types of tissue. We are going to have two groups of tissue, hematopoietic tissue. You are going to have the primary tissue. There are going to be two. The primary tissue is going to be the bone marrow and the thymus gland. Thymus gland is going to be the gland that's going to be in your thoracic cavity in front of the heart, and the blood vessels such as inferior vena cava, superior vena cava and aorta and things like that is going to be in this area, okay? And bone marrow. Those are the primary tissues. They actively synthesize the cells. Now you also got secondary tissues. They have the ability to make the cells. But usually when the cells are made in the primary tissue, bone marrow and thymus, then when they are ready to go to the body, they go to the secondary tissues and they reside there. They sit there. Each white blood cell has a function. Each white blood cell has a responsibility to do. And they sit there until they respond, they're called. When they're called, they are able to divide in the secondary tissues and they are able to respond to the trigger, whatever that trigger is going to be. Okay? Primary tissue versus secondary tissue. What is going to be the secondary tissue? Well, what's that? Your spleen, your lymph nodes, you got a lot of lymphatic tissue around your lungs. You have a lot of lymphatic tissue around your gastrointestinal tract. Those are all going to be secondary. Your tonsils. Your tonsils are secondary tissue. Your appendix. Your appendix is going to be secondary tissue. You will have a lot of white blood cells in that area. Okay? Think about it. Think about your intestine. Think about your intestine is going to be like this. This is where the cheeseburger is traveling, down here. Okay? You have a lot of bacteria here. How many cells do you have in your body? About, give or take, 100 trillion. 100 trillion. You have 10 times. I don't know what that number is going to be. What is after trillion? Zillion? I don't know. Googleian? Whatever that's going to be. You have 10 times more bacteria in your intestine than your cells in your body. So what I'm trying to tell you is this. You got an area with a lot of bacteria. You got an area that is completely sterile. Okay? I cannot use this glove. It doesn't let me write. What is the wall that separates these two worlds? You got a single columnar epithelium. You have looked at these under the microscope. You know what we are talking about. A small, thin, tiny, fragile cell. So life is not perfect. I'm sorry to inform those of you who are idealistic that there is something called reality. And in reality, things go wrong. And wrongness is that you have a breach in the wall. Bacteria is going to get to this sterile environment. You got to take care of the business right now. Otherwise, these are going to get into your blood and are going to give you septicemia and they're going to kill you. Okay? So what's going to happen here is that you have a lot of white blood cells around the wall of your trachea, your esophagus, your gastrointestinal tract, in order to protect, the integrity of that wall. Because there is going to be breach, but you don't want every time there's a breach, you get sick. Okay? All right. So those are all going to be lymphatic tissue as well, secondary. All right. So this is very important. Let me see whether I can go ahead and draw it for you just a little bit. Maybe I'll be able to go ahead and make sense out of it. I'm not sure. But let me draw it up here. Or maybe I'll draw it up there. There's bigger space. I want to go ahead and draw you. Let me orient you what's going on in here first. This is the bone. This is one of the long bones. Okay? I am cutting this bone in this angle. Pay attention so you can understand your orientation. And I'm turning this bone into showing inside this bone to you. So this is the inside. Everybody understand the orientation? And that's going to be the inside. So you are going to have a compact bone on the outer part, the cortex, but you are going to have something in this fashion. And where are your, this is going to be compact bone. This area is going to be compact bone. You are going to have the medulla in the center. Usually you will have blood vessels in here in the center that are going around in here. But where you are going to have your hematopoietic tissue are going to be in this area that I'm going to draw. So you will have cells that are going to be, let me draw, I want to enlarge this part. I want to enlarge this part and put it up here so everybody would be able to see. So that's that part, right? You will have the bone covered by a cell called endosteal. Endosteal cells are going to be covering the bone. These are bones, also known as trabeculae. So you will have endosteal cells. They're just covering the bone. One layer thin, simple squamous. They're going to be in here, covering the bone. You will have their osteoclasts, you will have osteoblasts, you will have all those population around in here. It's a bone. But then you will have hematopoietic cells. I want to make the hematopoietic cells just white. They're going to be in here. Okay? They're going to be in here. Around these hematopoietic stem cells, you're going to have two layers. You're going to have a layer of, there's different names we use, reticular cells, but also you can use adventitial cells. Reticular is the same as adventitial. I want to make those red again. Okay? And then around the adventitial cells, you're going to have another layer of cells. Those are going to be endothelial cells. Those are going to be on the outside. Now, let me go ahead and make some sense out of this thing in here. You remember I told you that red blood cells, they lose their nucleus before they come out into the circulation? For the red blood cells to develop, it's going to develop in here. For it to be able to go ahead and come into the circulation, it has to be released in here. So it has to go through the adventitial cells, it has to go through the endothelial cells before it's able to get into the circulation. I hope you are getting the idea where the nucleus is going to be lost. These guys are not going to let the red blood cell with the nucleus to go through unless there is something going on that requires the red blood cells to go through immaturely. These are the guys that are ensuring, hey, you want to pass through here, you got to have a specific size. If you have a big nucleus inside of you, you're not going to be able to go through. Okay? They're going to squeeze the nucleus out of the red blood cells. All right? So this is the general structure of the bone marrow. You got the hematopoietic tissue sandwiched between two other types of, tissues that are mostly going to be endothelial or fibroblastic origin. And what's going to happen here is that depending on what type of cell you are going to have, for instance, if you are going to talk about red blood cells usually are going to be found in the corners, in this area, for example. They're together. You're talking about megakaryocytes that are going to give rise to the platelets. They're going to be around area that's going to be close to the blood vessels. And their legs are going to be able to come out and release the platelets into the blood. If you're talking about white blood cells, they're going to be distributed, you know, pretty relatively uniformly throughout the hematopoiesis. So different cells are going to be localized in different areas. Why is it important? Whenever you're looking at somebody's bone marrow, you would be able to go and get an estimate, for example, what is the number of megakaryocytes. If I'm looking at the bone marrow, there are certain things I have to do. One of those things is going to be that to estimate the megakaryocytes, to understand, hey, this guy is having 50,000 platelets. What's going on? What is happening to the platelets? I do the bone marrow aspiration, I'll do bone marrow biopsy, I'll look at the bone marrow, and I'm estimating the megakaryocytes, which are very large. They are 50 micron in their width. So what's going to happen is that you will be able to see them at 10x easily. If I see between 2 to 10 megakaryocytes at 10x, that person is having not the right number of the megakaryocyte. If it has more or less, then that's going to pose that there's something going on in there. Questions? All right. You can see the same structures in here. The only thing I did not tell you is going to be these big white spots. Those are adipocytes. Those are fat cells. And the fat is due to the lipid vacuole. Each one of them has a big, large vacuole inside of it. Now pay attention. This is another important information that's going to be used quite often in this class. This is the bone. Let me orient you. These are bones. Okay? These are going to be bones. Trabeculae, I told you. This is the hematopoietic tissue. These are the lipids. And what is going to be a very important information for you when you ever look at the bone marrow, you want to read the report to understand, is the ratio of the cellularity. How cellular is going to be. When you are looking at the cellularity, you're comparing hematopoietic cells to the adipocytes, to the lipid cells, fat cells. What does that mean? It means that in an average individual, if you don't have any diseases in this room, and I do bone marrow biopsy on you and I look at your bone marrow, your ratios of the hematopoietic cells to the lipids is going to be around 50-50, okay? If you go below 30, you're going to be hypocellular. If you go above 80, you're going to be hypercellular. And that's going to be a key information that's going to allow the physicians to go ahead and make a diagnosis. Is the level of cellularity. Remember that. It's going to come back. So again, we already talked about all blood cells, not only red blood cells, all blood cells are going to come from the bone marrow. And they are going to have the same progenitor. One cell, the stem cell, hematopoietic stem cell, is going to give rise to erythrocytes, is going to give rise to megakaryocytes, is going to give rise to all white blood cells. All right. There is another organ that we call liver. Liver does a lot of things. I mean, liver is one of those organs that it doesn't just do one thing. It does many, many things. It produces things such as albumin. The most common protein in your blood is this protein, carrier protein called albumin. Extremely important in different carrying different molecules in the blood, or allowing the fluid comes from the tissue and get into the blood again. Let me explain to you what I mean by that, because that's a very important thing. This is going to be a very important concept. See, folks, this story is very simple. You got this heart of yours. Perhaps it has been broken a couple of times, but that's okay. Let's just put this arrow in it. Okay? This heart of yours, besides falling in love, has another function. And that function is to pump blood. Okay? How is it going to pump the blood? It's going to pump the blood into arteries. Artery. As the arteries are going to pump the blood, nothing is going to be exchanged between the blood and the cells in the body. Nothing is going to change. The arteries are going to get smaller and smaller and smaller. The smallest arteries, we're going to call them arteriole. And the arteriole are going to enter what we call a capillary bed. A capillary bed. If you are going to give oxygen to your cells in your body, you got to do it at the capillary bed. If you're going to get the waste products from your cells in the body and put it in the blood to get rid of them, you got to do that at the capillary bed. If you're releasing hormone in one place of the body and you are going to influence your cells in another place of your body, you got to do it at the capillary bed. So what's going to happen here? The blood pressure is very high. It's going to come in. Of course, you guys already know that the wall is made of what? What kind of cells are going to be there? Question for your quiz one, many of you missed. Endothelial cells. Endothelial cells, they can allow usually molecules to pass through based on their size. They're not going to allow red blood cells to go through. They are not going to allow proteins such as albumin to go through. But they will allow, for example, plasma with glucose, with hormones, with sodium ions. They would be able to go through. And your cells of your body are going to be all in here. So that plasma with all those things are going to be basically bathing the cells. So if I have this cell in here that is being bathed by this plasma, if I have a receptor to get the glucose in here, the glucose is going to come in. And it's going to come inside of the cell. You get the concept, right? So what's going to happen here is that what was the driving force of the blood into pushing the plasma into the tissue? What's that? Heart blood pressure. That's exactly what it is. Which heart is going to have enough force to push that plasma. Yes, big molecules, big cells are not going to go through. But everything else that's going to be dissolved in the plasma is going to be able to go through and is going to be able to come into the tissue. Now, think about this example and then we're going to go to the next stage. Think about there is a big El Nino rain coming down. And think about you're standing on a river, in front of this river. And El Nino and the rain and everything is coming and there's flooding coming and you are going to stand right in the middle of this river. You're going to be washed away. If you ever have seen flash flooding, you're going to wash away without, I don't care how big you are. He's going to take you just, you don't know where it is. But if this big river breaks down to 1,000 smaller rivers, and you stand in one of those smaller rivers, are you going to be washed away? No. What's going to happen is lower pressure, because as you divide this big pressure into smaller components, each one of them is going to have smaller pressure than the original one. You understand the concept? Same thing in here. After you divide this blood into thousands or hundreds of thousands of capillaries, by the time that the blood needs to be getting back into the veins, by the time that you're going to get the blood back into the veins, this is the vein, so you're going to go back to that broken heart. What's going to happen here is that there is no pressure left. Okay? There is no pressure left. What's going to be the key allowing you to get that blood back into your circulation? Albumin. Who produces the albumin? Liver. Why is this so significant? That's the most common protein in your blood. How is it going to be able to do it? Same idea as the fact that large proteins, large molecules cannot come out. So what is going to be the concentration of the solutes? If you are comparing the concentration of solutes in this area versus in this area, which one is going to have higher concentration of solutes in the blood? No. If the proteins cannot get out of the blood, they're going to stay in the blood. If the large cells cannot get out of the blood, so you are having some of the plasma getting out, but a lot of proteins and large cells cannot get out. They're going to stay inside of the blood. They're not going to come out. that's going to make this side more concentrated in the blood. The concentration of the solids is going to be higher in the blood in this side, on the side of venous, the venial side. Did you understand what's happening here? Because of the fact that large molecules cannot come out of the blood. They're going to stay in the blood. Some of the plasma is going to come with the small molecules. That's going to make the blood that's going to be in here on the venous side concentrated. Do you know what the answer is going to be now? How you are able to get the plasma that came out back to the blood? Osmosis. Osmosis is going to be the key. So what's going to happen here is that osmosis is going to pull out majority of that fluid, that plasma that got out, back into the cell, back into the blood vessels in order to send it back to the heart. Okay? Every day, 30 liters of your plasma is going to be filtered in your tissues. 27 liters is going to come back into your venous side, back to the circulation. There is a gap, there's a difference of 3 liters, and it would be the job of lymphatic system to get that 3 liters back to the blood vessel circulation. And they're going to happen right before the blood get back to the heart at the superior, at the left and right subclavian veins. That's where it's going to happen. The fluid is going to be poured back into the blood circulation. Now, saying that, I told you that because of the liver. The idea is that if you ever see somebody dying from liver cancer, you will be able to see that they are going to be blown up. They are going to be swollen up. I mean, you look at their faces and their, the skull is skin and bone. You can see their skull, just a thin layer of skin on top of it. But when you look at their abdomen, they are swollen up. You understand now why? Because liver produces the albumin. If you don't have the albumin in your circulation, who is going to pull that extra fluid from the tissue into the circulation? It's going to stay into the tissue and it's going to cause what we call edema. And that's what you will see in that connotation, that liver is not functioning properly. Okay? All right. Liver does a lot of things. You will see and learn a lot about how liver enables you. I just told you make 1 million cells per second. When you are making 1 million cells per second, you're going to get rid of the 1 million cells per second as well. So you're going to produce million, you're going to get rid of million. Liver plays a very important role in order to be able to maintain that function, to be able to get rid of things that you don't want to. The other things that you know, probably, hopefully from previous classes, is going to be liver plays a very important role in blood pressure control. Liver is the organ that's going to produce angiotensinogen, which when the renin hits the angiotensinogen is going to break it off and is going to result in the control of blood pressure by known mechanisms that we know exactly what it is. Liver is remember we talked about fibrinogen? Liver produces fibrinogen. Now you understand when you're having somebody is having liver disease, they're going to bleed. They're going to get, blue spots on their skin. They're easily going to bleed. They're not going to be able to clot their blood because of this. If liver is not making those proteins, nobody's going to be able to make it. Liver is the one that controls your cholesterol in your blood. Bottom line, liver does a lot of things. I don't want to spend the entire time talking about liver because I can't. I can spend 2 days just talking about liver and just fairly, scratch the surface. But liver also has the capacity of producing hematopoietic stem cells. As we talked about, in the fetal age is going to be primary responsibility. But if you have an adult, you sometimes see extramedullary hematopoiesis. Extramedullary hematopoiesis means this. You are making the blood cells in the liver. Or spleen. Extramedullary, not in medulla of the bone, outside of the bone. Liver and the spleen are going to be primary spots, but you will see in different places. I have seen x-rays of lungs, and you do it in the lungs, you do it in the other tissues, but liver and the bone marrow are going to be number one. Now in this image, I don't know how well you're going to be able to see what we are having here. We have removed all the intestines. Stomach has been removed. Intestines have been removed. This is the duodenum. This is the beginning of your small intestine. That's the only pieces left. What is this organ? This is pancreas. Behind the stomach. The stomach is removed so you can't see the pancreas. This is the spleen. Okay? This is the spleen up here. You got one. It's going to be upper left abdominal cavity. That's where you're going to find the spleen. Spleen is the lymphatic tissue. And it's very important lymphatic tissue because kidneys filter the plasma. Okay? Kidneys filter the plasma. If you got waste products, you get rid of it through the kidney. If you got too much sodium, you're going to get rid of it through the kidney. If you need to retain water, you're going to do it through the kidney. Spleen filters the blood. Filters the blood of what? When you are having to get rid of 1 million cells per second, for example, red blood cells, it's the job of spleen to get those old cells out of the circulation. Okay? If you are having the platelet that lives about 7 to 10 days, it's the job of the spleen to get rid of those old platelets. Another thing is that the spleen is going to act as a storage unit for a couple of things. One, you're always going to have about a couple hundred ml of blood extra in the spleen. If you need it, if your blood pressure drops quickly, your spleen, there's a muscle, smooth muscle around it, they're able to go ahead and squeeze and get that 200, 250 ml of blood into the circulation. So if I go ahead and stop you right now, and you are bleeding profusely, if I go ahead and take your blood pressure, I'm not going to see a drop in the blood pressure immediately. Yes, I'm going to see it drop in the blood pressure within 30 minutes if you're really bleeding, within 30 minutes, 40 minutes. But if 5 minutes afterwards I take your blood pressure, I'm not going to see a drop. You're losing the blood. Why there's no drop? But there are many different reasons. One of the reasons is that 200 ml that was extra in the spleen is squeezed into the circulation. Any questions so far? Spleen does a lot of things. So that's the place you're going to get rid of the old cells, red blood cells, platelets. That's the place that you are going to have that extra, you're also going to have another thing. You also, at each time, you're going to have about 30% of your platelets stored in the spleen. 30% you're going to have a storage of platelets in your spleen. Spleen is not going to be an organ that is essential for life. I mean, it has a function. But for example, in boxers, there is a big artery down here. This is the artery. I don't know how well you're going to be able to see. That's called splenic artery. It's a huge artery. It's easily you can under X-ray and things like that, you would be able to pick it up easily because it's twisted. It's twisted and it's easy to identify. If the boxer gets hit in there, that's why it's illegal to hit the boxers in this area, because if you go ahead and damage that junction of the spleen and the splenic artery, you're going to start bleeding. Spleen has a lot of blood supplies, so you're going to bleed profusely. What happens is that they remove the spleen. They do a procedure that is called splenectomy. A splenectomy when they remove the spleen. So yes, it is a fact that if you are removing the spleen, you're going to be a little bit more prone to cold and illness, a little bit more than average individual. But you can survive. You can have a normal lifespan as anybody else. But you're going to be a little bit more prone to various illnesses, flu and things like that. Okay. When you are looking at the spleen, it's going to be a very unique architecture because of the fact that you will have basically two unique, distinct areas. You're going to have an area called white pulp, and you will have an area that is going to be down here. You don't see it very well. That's called red pulp. So imagine that big artery is going to bring the blood into the spleen. Imagine what's happening in the spleen. As this big artery is bringing the blood into the spleen, a couple of things is going to happen. Spleen has a lot of reticular fibers, cells, fibroblasts that set the reticular fibers. So there is going to be this net. So if you look at the spleen, if you're standing and I have a big spleen in front of me, it's going to look like this. is going to be a net of reticular fibers. Okay? So if the blood wants to go through, it has to go through these fibers. The spacing between these fibers is very small. So what's going to happen, the plasma easily can go through. But there is going to be a delay for the red blood cells and platelets. Imagine if there was 10 doors in here, all the 10 doors are going to be open. From every door, students are continuously coming in, and there is going to be only one door out. You're going to be building up in here until everybody be able to get out, right? Same thing is going to happen in here. As the blood is coming in, the plasma might be able to go through, but the red blood cells are going to slow down. This slowing down is going to be very critical for the function of the spleen. And this is the reason. As you slow down, there is a number of things that are going to happen. One, you're going to develop hypoglycemia in those cells, not in your body, in that area. Which means that hypoglycemic, which means the glucose level for those cells is going to go down. You're going to develop hypoxia, which means the level of the oxygen in the spleen is going to go down. And you are going to make the blood more acidic. The pH is going to become lower, is going to become more acidic. All these factors are going to be critical in order to identify who is the old cell. You got to ask yourself, how is this possible that you are able to identify the young cell from the old cell? When you are making the situation and environment tough, the old cell lose the game. And they are going to be picked up by these macrophages that are going to be in here, and they are able to phagocyte by two methods. They are able to do two methods to get rid of the old cells. One is going to be called culling, and the other one is going to be called hitting and culling. Culling is that the macrophage is going to eat the entire old cell. Okay? Hitting is a very important concept because we're going to come back to it very soon. A couple of you have already stopped by my office and talked about, white cells. White blood cells look like white cells because they went through the pitting. Sometimes these macrophages, if this is the red blood cell and if you are having some kind of anomaly on the membrane, they're going to pit it. They're going to be able to get this part out. Sometimes you are having different components, such as a part of the nucleus still left inside of the red blood cell. The macrophages are going to just take this part out, and what is going to be left is going to be able to pass through until it gets older and older. Okay? So that's going to be the concept. You're going to do all these things in the liver. Now, in the spleen. So what happens in the red pulp is that the blood comes in, red blood cells are going to slow down, they're going to go through this, and that's going to stress them, and they are going to go in and identify which cell is going to be older, needs to be removed from the circulation. What happens in the white pulp? These are all going to be white blood cells. Specifically, they're going to be lymphocytes. A lot of lymphocytes and macrophages are going to be there. Why? Well, remember, spleen is going to filter the blood. If it's going to filter the blood, if you got a bacteria there, the macrophage up here is going to capture the bacteria. It's going to go in and break down that bacteria to small pieces. And then it's going to put this bacteria, let me go in and use this. It's going to phagocyte that bacteria. This is macrophage. It's going to break, let's say this is going to be our bacteria. This is the bacteria, and every cell is going to have markers on its surface. Let's say that this is the marker on the surface of this bacteria, and there are more than one, okay? So what's happened is going to eat this guy. It's going to break it down. It's going to attach it, this different part of this bacteria on a protein, and it's going to make this protein to come to the surface of the cells. And that is going to have its pieces of the bacteria. When we were talking about, I don't know whether or not it was this class, we were talking about major histocompatibility complexes, MHCs. These are the guys. Not class 1, this is going to be class 2. But these are the cells, this is the way that the cells are able to communicate. They're going to put this one up here. Okay? These are called antigens. And then this macrophage is going to come up here and it's going to go down to the white pole. And it's going to present that antigen to the white blood cells. Guys, this is the enemy. We need to deal with this one. And the white blood cells are going to do what we're going to talk about detail later on. Okay? This is the way that you're able to identify the non-self and destroy the foreign non-self antigens in your body. Spleen plays a very important role. Now, your spleen can get very large. Your normal spleen is going to be something about this size. It's about actually, I have done many autopsies and dissections. I would say a normal spleen is the size of your fist, up here, okay? But look at the spleen of this kid. First, you can palpate that. You can feel it, you can see it, you can touch it, you can push on it, and you can be able to see the resistance. What's going to happen, this is the spleen from this kid. This kid has sickle cell anemia. So what's going to happen, remember what I just told you here. It is going to be a very difficult networking here that the cells have to go through. In the sickle cell, the cells lose this discoid or biconcave shape and they become sickle shape. And the sickle shape is going to get cut in here. Whenever it's going to get cut in here, what's going to happen here is that the spleen, in order to be able to accommodate, is going to get bigger. And it's going to get bigger. And it's going to get bigger. These people are going to lose their appetite. Why are they going to lose their appetite? Because the spleen and the stomach are very close to each other. The spleen is going to be so big that's going to push on the stomach, and the stomach cannot even open up. So that's going to have something to do with their losing their appetite. It starts pushing on organs. It starts pushing on blood vessels. So it's going to become dangerous. You have to do a procedure we call splenectomy. You got to remove the spleen. Okay? And that's what has happened in this case. Sometimes we are having autosplenectomy. Autosplenectomy, it means that these sickle cells, for example, they got so much cut in this network that they just block the pathway of the blood. So what's going to happen is anything distal to that pathway is not going to get blood, it's going to die out. So the spleen is going to be in the body, but it's all dead. Okay? It's autosplenectomy. So the spleen is not working even though it has not been removed. That's what autosplenectomy is because of those infarcts that happen there. Lymph nodes. Each individual is going to have different number of lymph nodes. Something about 200 to 300 of these lymph nodes are going to be in our body. They're going to be more common in different regions. So you're going to have your axillary regions under your arm. You're going to have a lot of them. You're going to have in the groin area. You're going to have called inguinal area. You're going to have a lot of them. You're going to have a lot of these things, around your gastrointestinal tract. These are lymph nodes. But look at the architecture of the lymph node. Regardless you are 200 or 300, look at it. There is always, for a lymph node, is going to be, let me tell you what lymph node is first of all. Lymph node is a part of lymphatic vessels, if you don't remember. Lymphatic vessels, you know where the origin was? I already told you where the origin is. So you remember that 3 liters? When I told you that 30 liters is going to come to the tissue, only 27 is going to get back into circulation. 3 liters is going to be left into the tissue. Who is going to be able to bring that back to the circulation? Is going to be lymphatic vessels. Lymphatic vessels are going to start with lymphatic capillaries. So lymphatic capillaries are going to bring that 3 liters into their vessels, and the small lymphatic capillaries are going to come and join and become larger and larger and larger and larger, and the largest one are going to empty that. Lymph is the solution that's going to be traveling inside the lymphatic vessels. We call that lymph, okay? That's what it is. It's going to be primarily consist of plasma. It's not going to have any red blood cells. It's not supposed to have platelets. It's not supposed to have large proteins, but it's going to be able to bring that extra 3 liters. As it's going to come back to our heart from the tissue, you can see we're going to have these, I'll call them garrisons. I'll call them, army bases. That you will have different vessels coming in. You're only going to have one vessel going out. So we call these afferent lymphatic vessels. This is the efferent lymphatic vessels. The pathway is toward the heart. So different lymphatic vessels are going to come in. But look what's going to happen. These are reticular fibers in here. They create this platform that the cells can sit and attach to it. They create this what we call substratum. you're going to have a lot of macrophages in here. Macrophages are able to see what is in the lymph. If there is an old cell, they're going to destroy it, phagocyte. If there's a bacteria or cancer cell, if they catch it, they're going to break down, as I've exactly told you what it is, and they're going to bring it up to these lymphatic nodules. You see these in here? These are a lot of white blood cells in the cortex of the lymph node. A lot of white blood cells. So macrophages are going to present those antigens to these cells, lymphatic tissue in the cortex, and these cells, based on whether or not they are responsive to that antigen, they're going to respond. They're going to start divide, and they are going to make more of themselves. Let's say that you were just exposed to a virus, like mumps. What is mumps? It's a virus. You have been getting vaccination for mumps. When you get vaccination, you activate your white blood cells. Mostly are going to be in the bone marrow and the thymus. When you make it, when they're mature, they're going to go into the lymphatic tissue. Let's say this is going to be one of those places that one of those cells is going to come and reside in one of these cortical lymphatic nodules. So you have a white blood cell, specifically a lymphocyte, that is going to be responsive to mumps only. When they become responsive to something, that's the way they're going to be for the rest of their lives. If I am a lymphocyte, I am going to have one person that I'm searching for. My job is to go ahead and capture Al Capone. That's it. Now, I am not going to worry about the right man hand or the left man hand. I'm going to have or just go for the Al Capone. That's the only body I'm caring about. Same thing is going to be with lymphocytes. They're only going to have one target. In this case, our lymphocytes is going to be able to identify mumps virus. You're exposed to the mumps virus. What's going to happen is that macrophages are going to capture it. Macrophages are going to present it to the lymphocytes in here, and those lymphocytes that are going to respond to that antigen for the mumps, they're going to go through crazy mitosis. They start dividing. They start making things we call antibodies. They start sending the cells all over the body. They respond. Now you understand when you go to the doctor and they're checking your lymph nodes. If your lymph nodes are swollen. Because when the cell goes through mitotic division, a lot of mitotic division, what's going to happen to the size of the lymph node? It's going to become large. And that's what they're checking under your skin. Because you can feel some of the lymph nodes right under your jaw. Okay? Questions? All right. Unfortunately, that's a fact of life as well. That there are two ways. You know, when you are getting a melanoma cancer, that melanoma cancer doesn't kill you. What kills you is that melanoma cancer is able to travel to your liver, to your colon, to your brain, and that's the way it's going to be taking care of your, as time passes by very quickly. What happens is that there are two ways for the cancer cells to travel. One is going to be through the circulation, through your blood. The other one is going to be through the lymphatic system. Okay? That's going to be the two ways. So that's why if you hear somebody, for example, I don't know, if somebody has breast cancer, okay? Somebody has breast cancer, they find the tumor, and they're going to remove the tumor. When they remove the tumor from the breast, they also remove several different lymph nodes along the path. Then they send the lymph nodes by one, lymph node number 1, number 2, and number 3. They send it to the pathologist. The pathologist cuts these lymph nodes, makes a slide, stains them, and looks for the cancer cells, because cancer cells are going to have different characteristics. If you see cancer cell in the first lymph node, you see cancer cell in the second lymph node, it's very likely that the cancer has metastasized throughout the entire body. You don't see cancer in the first one, second one, third one, there is no guarantee that it has not metastasized. But your chances are pretty good it has not. Okay? There's no guarantee in your body. Okay? There's just no guarantee. But the chances are very well that you probably not allow that cancer cell to be able to get other places in your body. Okay? That's why they remove the lymph nodes. Okay? Because that's the primary way for the cancer cells to be able to travel inside the body. Lymphoma versus leukemia, I will tell you more about it when we come to white blood cells. Thymus. As I told you, thymus is going to be the yellow, I made it yellow, it doesn't look yellow like that. But it's going to be in the space we call mediastinum, right in the center of the thoracic cage, right in front of the heart and the great vessels of the heart. This is the first organ that develops fully in a fetus. Okay? The first organ that develops fully in the fetus is going to be thymus. The way that's going to happen is going to be this. All blood cells are going to come from the bone marrow. All blood cells are going to come from the bone marrow. Lymphocytes are going to come from the bone marrow as well. But in the case of one specific subtype of lymphocyte, we call them T lymphocyte. T for thymus. These lymphocytes, even though they have originated in the bone marrow, they're going to come into the blood immaturely. They're immature. They're going to go to the thymus. Now, if you look at the thymus histology, you will have a cortex and you will have a medulla. The blood vessel is going to bring these new immature cells into the cortex. And they're going to stay there. And they are going to be maturing. Out of every 100 T cells that comes to the thymus, 95% of them are going to die by apoptosis. They will die by apoptosis. Programmed cell death. That's part of the game. That's part of the way that your body works. Think about this. Do you want your white blood cells to respond to your own cells? That's what's going to happen in the thymus. If a white blood cell responds to your own antigen, it's going to trigger cell death. They're going to die. So you're going to find out who is going to respond to your own cells. You're going to kill it. You understand where I'm going with this? You understand autoimmune diseases? Have you heard of autoimmune diseases? What happens in autoimmune diseases? Your immune cell respond to your own cells. Something goes wrong. Okay? Now where it is, that's going to be a much more complicated discussion. But the bottom line is that only 5% of T cells are going to mature. As they mature, they're going to come into the medulla, and from the medulla, they're going to go to the different places. Different places like what? Like a spleen, like liver, like lymphatic tissue. And they're going to stay there until they are called for to fight a specific enemy. Okay? All right. What else I can tell you about thymus? Thymus is mature when you're born, completely fully developed. It's going to get a little bit bigger until the age of, when you're teens. After your teens, you hit the puberty, everything is going to go down the hill. Your thymus is going to get smaller. I have opened up, bodies, and then I looked at, for example, I couldn't find the thymus. They're actually so bad, you don't even find it in a 75, 80-year-old person. You don't find the thymus anymore. It's become so small because everything that they still have the ability to make these T cells mature, but the size becomes so small because the primary job has been already done early in life. If a child is born with a tumor in the thymus, so they have to remove the tumor. You know what that happens? Have you guys heard of bubble boy? Because they put this is a real case. They put this kid in a bubble house. Everything was inside of the bubble because inside of that bubble, everything was sterile. Because he had lost his thymus at the time of birth, he couldn't develop any immunity. Everything that you and I can respond would kill him. So they have he ultimately died because he had the exposure. But again, the idea is that he didn't have thymus. That's what happens. You cannot develop a competent immune system. Stem cells. Now, many of you have heard a lot of things in the news and things like that about stem cells, and it's very interesting when you listen to the media and you realize that some of these people that are considered experts and they come and talk, they don't have the slightest idea of what the hell they're talking. And that's really sad because they got the microphone and they're talking all this nonsense, and people who are sitting and they don't know anything, they are going to be misguided, and that's really sad. And it's getting worse and worse as time goes by. So the idea of stem cell is this: we have different types of stem cells. Listen to me, and I'm going to go ahead and tell you what is going on. So hopefully you're not going to fall for that kind of mistake. You got the sperm and egg fertilize each other. You got what? Zygote. Then the zygote is going to go through divisions. Zygote is going to become 2 cells. Then zygote is going to become 4 cells. Then 4 is going to become 8. 8 is going to be 16. 16 is going to become 32. 32 is going to become 64. Around the 32 and 64, listen up. If I remove this, we call that morula. If I remove this ball of cells, 64 cells, and separate each one of these cells, make 64 cells. Each one of these cells is going to become exactly the same human being as the other one. So you would have, I don't know, if you're having twins, two triplets, 64lets, it's a word like that, I don't know what that is. You will have 64 individual, complete, normal individual. Because at that stage, those cells have the capacity of making the whole organism. Okay? They are able to, they have the capacity of making amniotic sac, they have the capacity of making the yolk sac, and they have the capacity of making the embryo. At that stage, we are having a type of stem cell called totipotent. Totipotent. Okay? Totipotent. A totipotent cell can become any cell in your body. You have 200 different types of cells in your body. Can become any one of them. Okay? But as this division from 64 moves on and the cells divide and there are going to be layers of the cell, and some of you might have heard of endoderm, ectoderm, and mesoderm. When we are getting to that stage, you are moving from the totipotent cells into pluripotent. Pluripotent cells are going to be cells that they can become many cells, but not every cell. For instance, if I get one, there are going to be layers in that embryo. If I get one cell from the part we call mesoderm, the middle layer, that mesoderm can become bone, it can become muscle, it can become blood vessel, but it cannot become skin cell. It cannot become a nerve. Okay? Because by that time, they are pluripotent, they can become different cells, but not every cell is going to be made. But they're going to become a lot of different types of cells they have the ability to become. The next stage is that you are getting into stem cells. The stem cells, for example, I'm going to use the example of hematopoietic stem cell. Hematopoietic stem cell is the cell that is found in the bone marrow. It has the capacity of becoming different cells, but only blood cells. It's not going to become, for example, endothelial cells anymore. It's going to be able to become blood cells. It's going to become neutrophil. It's going to become eosinophil. It might become basophil. It might become a lymphocyte. It might become a red blood cell, or it might become a megakaryocyte. That is going to be hematopoietic stem cells. Okay? These are the different stages. Sometimes people are saying that, why don't you go in and use hematopoietic stem cell in order to study the stem cells? Because hematopoietic stem cells is a wonderful tool to study blood cells. But if you are trying to go ahead and look at the neurons or nerve cells or pancreatic cells, these are not the ideal ones. They are going to be this one or this one are going to be the most powerful that's going to replicate the situation. However, just throwing that out there, we have learned something. We have learned that all these divisions are gene expression. I hope that you already realize that, gene expression. We have learned techniques in which we would be able to get the hematopoietic stem cell, shut off some of the genes, activate other genes, and the hematopoietic stem cells is going to go backwards. It's going to become pluripotent, and it's going to become totipotent. Okay? That's the technology that is happening right now. It's very advanced technology. Questions? Okay, there were two ideas. One of was monophyletic, the other one was polyphyletic. The idea is very simple, and now we know exactly that it's going to be mono. Monophyletic is going to be the time that, so the idea was that we were thinking that, okay, white blood cells have their own stem cell, red blood cells have their own stem cells, platelets have their own stem cells. And they would be able to divide and make the corresponding cell. We learned that, no, that's not going to be the case. We have one stem cell, hematopoietic stem cell, has the capacity of becoming any one of the cells in the blood, any one of them. So we already know that monophyletic is going to be the accurate one, and polyphyletic is going to be discarded. And this is the way it's going to work, people. You got the stem cell up here. And this stem cell, depending on which direction things happen, depending on what triggers are in the environment, you're at the point that you should be able to give me one example of the triggers. What trigger is going to push this stem cell, for example, to become a red blood cell? Erythropoietin. Erythropoietin is one of those triggers that if it is in the environment, is going to make this stem cell become a red blood cell. If you had another trigger called thrombopoietin, it would make it to become a megakaryocyte. Depending on what is the environmental cue, depending on what is the need of the body, this stem cell can go this way, or that way. And that's wonderful. Gives flexibility to the body to respond to the environmental conditions. Look at this image and understand the concept. This guy is the stem cell. It has to come down this road. Down here you got, for example, platelets. In here you got red blood cells. In here you got neutrophils. In here you got lymphocytes. Depending on this trigger, such as erythropoietin, such as the thrombopoietin, this stem cell might go a little bit this way, come out, become a neutrophil, or come this way, come out, and become a red blood cell. Questions? You understand what I'm saying? Everybody? And that's the story about stem cells. That's realistic. Is anybody having any question about stem cells they don't understand when they hear it in the news and things like that? You can ask, you know? If you don't know something, just ask it. And I am not too fan of all of these. There's a lot of layers. If you were, if this was, if you were an old graduate student getting your doctorate degree in hematology, I will tell you all about these things. But for the purpose of this class, I think that's going to be a little bit beyond the scope of this class. But I want to understand interleukins and things like that. They are going to be the triggers that are going to push things. Let's see. Red blood cells, EPO, that's erythropoietin. Where are the megakaryocytes? This TPO, that's the thrombopoietin. These are the triggers that decide which direction the cell is going to go. Don't sit down and memorize this chart, I mean, I expect you to know what erythropoietin is, but I don't want you to go and sit down and memorize things like that. Because if you want it, just look it up. Cell phenotype, okay, there are two general groups of cells when you are talking about the bone marrow. Of course, you're going to have the red blood cell, hematopoietic cells, that's pretty clear. But you will have myeloid versus lymphoid. When we are talking about myeloid cells, we are talking about neutrophils, we are talking about monocytes, we are talking about eosinophils, we are talking about basophils. When you are talking about lymphoid cells, we are talking about lymphocytes. You have T lymphocytes, they mature in its timeless, but you also have the B lymphocytes. Why do we call B lymphocytes? Where does the B come from? Bone marrow. That's where the B is coming from, because that's where these cells are born and mature. T cells are born in the bone marrow, but they mature in the thymus. And you also got another type of lymphocytes. We call them, that's the coolest name, we call them natural killers. Natural killers. Don't mess around with natural killer, okay? Because of the fact that any one of us in this room produces cancer cells every day of our lives, okay? Every one of us is going to produce cancer cells. But not all of us are going to get cancer. Why? Because we got these bad boys called natural killers. They are able to find them and they are able to destroy it. That's what happens. Whenever your immunity goes down, the function of these cells goes down, the cancer cells are going to get the upper hand. Okay? So I want you to realize that. And I have nothing against anybody who's doing whatever they're going to go and do as long as they're not harming somebody else. You can do anything, and it's okay with me, as long as you're not harming anybody else. So I'm not trying to go ahead and say anything. I'm just using an example. People who smoke cigarettes, okay? Smoking cigarettes. And I smoked cigarettes for 15 years myself, so I'm not saying that it's just, it's a habit that I think it was imposed on us without realizing that it's addictive, and we got trapped, okay? And I think that's the way. But bottom line is that when you're smoking cigarettes, there is nothing evil about cigarettes. There's nothing evil about tobacco. But when you're smoking it, you're shifting your body's response. You're making your immune cells weaker, and you're giving the upper hand to the cancer cells. This is the way that the cancer cells are going to get the upper hand. Because of the cigarettes and the compound, not the nicotine. Nicotine is the addictive part of it. But you got 200 other compounds in the cigarettes when you're smoking, which are going to shift the scale toward cancer cells than your body's immune cells. That's the idea that we need to understand. I remember you guys were not, most of you were not born. At the time of Reagan, Nancy Reagan had this advertisement on TV. I remember that, it was maybe it was an egg And I would say, this is your brain. And I would take the egg and put it on a frying pan, and the egg starts, boiling and, cooking. And I say, this is your brain on drugs. I don't like that approach. Just say no. They would say, just say no. I would say that educate people. Tell them how it's going to affect your body. Most of the people are going to make the right decision. Stop scaring people. This idea of scaring people, scaring people. I was so scared when I was coming from Ohio to come to California. I drove, my wife and I, we both drove all the way. We had to go through Colorado. I got so scared. I thought, oh my God, they're going to kill us in there because everybody is going to be on drugs, because the marijuana is legal there. I was so scared. And I went there and, there was no such thing because I have so much media to scare the heck out of me. And none of that is happening. People are just fine. Everybody's fine. Oh my gosh, Anyhow, we were almost dead. We almost got into, because it was snowing and in one of the roads, we really got into close to getting bad accident, but we survived. Anyhow, bottom line is that understand the reasons behind things. Don't just, you are not empty flash drive. You can think for yourself, okay? That's what education is. Education is not the degree. Education is a state of mind, the way you're thinking, that you're not going to agree with everything that you hear. You're going to think about it before you agree, okay? Whatever that's going to be, it's going to be. All right. We're going to go to the next lecture, and I got to make it 3 lectures today just because I want to go ahead and show Meryl that's going to happen. Okay, Meryl, it's going to happen. So we're going to go to the next one. What? You want to? After this one, I'm going to give you 5 minutes break. Okay? Oh, you want a 5 minutes break right now? Yeah. Go on. 5 minutes. We are. All right, so now this lecture is about bone marrow examination. Listen guys, bone marrow examination is going to be the reference. Anytime that you are having blood disease, sometimes you draw the blood, you would be able to diagnose, for example, somebody is having anemia. You draw their blood and you look at the red blood cells, you see, oh my gosh, red blood cells are big. Their MCV, normal range for MCV is what? MCD ranges 80 to 100. You see this person is having an MCD of 120. Wow, red blood cells are going to have large volumes. Then you look further, you see that neutrophils, usually their nucleus is going to have 3 to 5 segments. You see this neutrophils in this patient, some of them have 7 or 8 segments. Immediately, you got all the clues you need in order to go ahead and suspect that the person is going to have vitamin B12 and folate deficiency. You go ahead and do a test for vitamin B12 and folate, you're going to get your answer. You're going to make a diagnosis. That's exactly what it is. However, not always you're going to have that luck with identifying the disease. The bottom line is that anytime that you cannot find the answer, reference method is going to be bone marrow aspiration and biopsy. 2 different procedures are being done at the same time. Aspiration and biopsy. You got to examine the bone marrow because that's where the story is going to start. So we already talked about the fact that there is going to be a different time in growth. We also talked about the fact that you are going to have, as you are getting older, the bone marrow is not going to be found anywhere. Especially appendicular place that is going to only have bone marrow is going to be the proximal end of the femur. But you will be able to still have in the bone of your sternum, your scapula, and ribs, as well as your pelvic bones. So whenever they're going to go ahead and draw bone marrow, you're going to do the bone marrow examination, they have to go ahead and do 2 things, bone marrow biopsy and bone marrow aspiration. In order to do that, the best places to do it, number 1, and this is, I'm just saying it for the sake of the patients. If you are going to get a bone marrow from a chest of somebody, from the sternum, it's very painful, okay? So you got to go ahead and look at other possibilities if you have the choice and option, okay? If the person is going to be, there's nothing contradictory. The best place for aspiration and biopsy for the bone marrow is going to be the pelvis, the pelvic bone. what part of the pelvic bone? Number one area is going to be superior posterior iliac bone. Superior posterior iliac bone is going to be right up here. That's number one. If this is not a good site for whatever the reason is, then you are going to have anterior superior iliac bones. The one on the front part, that's going to be a good place to go ahead and draw bone marrow as well. If you don't have any of those two options, then you would be able to go to the sternum. Otherwise, I have seen this being done outpatient, and I see that the patient even didn't realize, you know, they were drawing it. He's just saying that somebody's pulling my leg. That's it. But I have also seen people draw bone marrow from the sternum, and the person was screaming so badly, it was grave pain, and that was not fun to watch at all. So just be aware of that one. So this needle is a unique needle. It's hollow inside of it. We call this just Jamshidi needle. And this Jamshidi needle is sharp, you know, it's like a big, you know, poking sword that you're going to go in and put it inside the right spot by feeling where you're supposed to be. And you're going to get into the bone. You're going to go in and drill into the bone. You're going to go inside of it, then you're going to remove this part of it. You're going to have just this needle in there. Then you would do two different procedures. One is aspirate. Aspirate is very simple. You're going to get a syringe, empty syringe, usually a 50 ml syringe, like this, or 25 ml, whatever the size is going to be, and you are going to start pulling on the plunger. By pulling on the plunger, you are going to start sucking in those hematopoietic cells. They're all going to come into the syringe. Immediately, if you have a, you know, somebody is going to be assisting you, you're going to go ahead and remove the syringe. They're going to, right by the bed, they're going to make the slides for the bone marrow. And then you're going to be able to do other things. You're going to put it in the tubes that it doesn't allow the bone marrow to clot. Okay? It has EDTA, removes the calcium. If you don't have the calcium, you're not going to be able to clot. They send it to flow cytometry laboratory. Flow cytometry laboratory is able to go ahead and use flow cytometry apparatus and divide the different groups of white blood cells, red blood cells, not by doing 100 cells, by counting 100,000 cells, and say out of 100,000 cells, you know, 10% in neutrophil, 20% is this, 20% that. That's the job for flow cytometry. Ratio of different cells are going to be determined, okay? If you are looking for cancer cells, you're going to go ahead and add the specific antibodies or markers that are going to bind to the cancer cells, and that. Did I start my thing or no? I forgot. Did I?
Yeah, you did.
Okay, I did. Okay. So you would be able to identify whether or not, for example, this type of cancer cell is present, that type of cancer cell is present. You would be able to do those. That's the aspiration. You are aspirating actually the liquid marrow coming in. But there is another part of this bone marrow examination. That's going to be biopsy. You remove the syringe, you're going to go ahead and put a hollow needle in there, and you actually going to drill into the bone. And you're going to remove the needle, and the bone is going to come with this. The entire bone is going to come, and that's going to be important. Because this is the way you're going to find out the cellularity ratio. Remember, this is going to tell you what type of cells are going to there. But it's not going to tell you about the ratio. Remember I told you today, it is very important to know what is the ratio of your myeloid cells to your fat cells. This is the way. With the biopsy, you would be able to determine that whether or not you have a marrow that is hypocellular or hypercellular or normocellular. There are many tests that you would be able to do on those cells, you know, on the biopsy as well as the aspirate. One of the important one is using Prussian blue. In order to detect iron, Prussian blue is used to detect iron. Iron is a wonderful thing. Every red blood cell is going to have iron in it. But the thing is this, sometimes if you don't have enough iron, you're going to have anemia. Okay, we call that iron deficiency anemia. Sometimes if you have too much iron, you're going to develop a disease called hematochromatosis, which is iron overload. You're going to have too much iron in your body, and that's going to cause your heart to fail, that's going to cause your liver to fail, that's going to cause your pancreas to fail. So too much iron is not good, too little of it is not good. You're going to maintain the homeostasis. By looking at the bone marrow and you finding out using the Prussian blue, you would be able to estimate the content of iron in the bone marrow, which is going to be very important in identifying, is the patient having anemia because they don't have enough iron, or is the patient having, you know, iron overload because they have too much iron. But again, this is going to be the most important data that you're going to get from the biopsy. The cellularity. These are the fat cells. This is the bone. This is the bone. These are going to be the hematopoietic tissue. There is a lot of hematopoietic cells in here compared to fat cells. I would say about 70 to 80% cellularity up here. On the contrary, look at down there. This is going to be the opposite side. This is going to be about 30% cellularity. So one of them is going to be on the high end, the other one is going to be on the low end. This is going to be critical in order to diagnose the patient, what the patient's anemia is, what kind of leukemia the patient has. This information is going to be key. What is the average normal range for the cellularity of the bone marrow? 50-50. 50-50. You go below 30%, you're hypocellular. You go above 70%, you're going to be hypercellular. And that's something that you should remember. Okay? Again, these are the two lists of the things that need to be done on a bone marrow aspirate and bone marrow biopsy. Different type of cells that are going to be the content of iron that's going to be there, hypercellularity, hypocellularity, the different type of cells, all those things are going to be done on the bone marrow. You can see the listing in here. Okay? And I think that majority of these things I already covered, in previous lecture, but again, if you have any questions, ask it now about bone marrow biopsy. You understand why you're doing it, and you understand what kind of information is going to be important when you do these procedures. Okay, this is going to be the lecture, basically going to be chapter 8. Now, we are talking about, we're going to place our focus. This is the junction. So far, basically, we were talking about background information. Now, we are going to focus on a specific group of hematopoietic cells. We're going to focus only on red blood cells. Then later on, we're going to focus only on white blood cells. That's going to be the second part of the course. Now, we're going to start our journey in the red blood cell world. What's going to happen here is that we're going to talk about where are they coming from. You have a little bit of an idea where they're coming from. They are all coming from the stem cell, we call hematopoietic stem cell, that is found in the marrow. So there is going to be a little bit confusion as you guys can start reading the textbook or what is available in the literature and on the web. There are different terminologies that are being used. And I am confused about it. I learned it one way, but it depends on whether or not you're European or you're American or you're British. You use different terminologies. All these terminologies are describing the same thing. So the cell that is going to become red blood cell, mature red blood cell, is going to come from bone marrow from a stem cell. It's going to differentiate through the processes and is ultimately going to become a very immature red blood cell. We're going to go ahead and call this one, again, depending on what type of terminology we're going to use. I learned to call it normoblast. But again, I'm going to tell you all about different ones. Normoblast. Why am I calling this a normoblast? Because this is the first stage that I can identify this cell is determined to become a red blood cell. This cell at this stage, when it's going to be in here, is not going to become a white blood cell. This cell is not going to become a megakaryocyte. This cell is differentiated and will become a red blood cell eventually. Okay? But there are different stages for this red blood cell. You're going to have normoblast, you're going to have the pronormoblast, you're going to have the normoblast, you're going to have the polychromatophilic normoblast, you're going to have orthochromatophilic normoblast late and early stage. You're going to have your reticulocytes that are going to be released, and you're going to have your mature red blood cells. Let's focus on the terminology because I want you to become familiar with all these terminologies. You don't have to use all of them, but if I use either one in the exam or something like that, you need to know what I'm talking about. You got the erythroblastic, normoblastic, and rubroblastic terminology. They are all describing the same thing. In the case of the erythroblastic, more of the British type called, British came up with this, terminology, nomenclature. You're going to have pro-erythroblast, the first one, the one that is going to be, you're able to identify it. The next stage is going to be basophilic erythroblast. A basophilic erythroblast is going to be smaller in size. The cytoplasm is going to be bluish. There's a very unique way to differentiate between this guy and that guy. Very simple. And that's going to be the chromatin pattern in the nucleus. The chromatin pattern in the nucleus is going to become condensed. It's going to be very smooth in here. As you go this way, it's going to become condensed. Okay? We'll talk more about it. I have better pictures. After the basophilic erythroblast, you are going to get into polychromatic or chromatophilic erythroblast. Again, the cell size is going to become smaller. Look at the cytoplasm. It's going to become a little bit lighter because you're getting the hemoglobin mixed up. You're producing hemoglobin. So that hemoglobin is going to overtake the ribosomes, ribosomal RNA, ribosomes that are making the cytoplasm. That's why the cytoplasm is blue. Because this cell is actively producing protein. In order to make the protein, you need the ribosomes. In order to have the ribosomes in the cytoplasm, your stain is going to be this dark blue. But one of those proteins, the main proteins that is being produced is hemoglobin. Hemoglobin has iron in it. Iron is going to give a different color than the basophilic color. It's going to have a pinkish color. And you can see gradually the pink is going to become apparent as the cell going to go through. So this is going to be the polychromatic or chromic erythroblast. The next stage, the nucleus is going to become really condensed. It's called orthochromic erythroblast. And then you're going to have the reticulocytes, and finally you're going to have the erythrocytes. This is one way, and it's valid, but you know, it's a British way. Normoblastic, this is the way I learned it. I'm not, favor of one around out there. I just want you to be familiar with it. Pronormoblast, same cell on top, the one that you are going to be early identifying is going to move into the basophilic normoblast, polychromatophilic normoblast, and orthochromatic normoblast, reticulocyte, and erythrocyte. And a bunch of European people said, oh, we got to stop, these Americans and British fighting each other, so let's come up with the new way. They add more, confusion to the whole thing. So they came up with the idea of rubloblast. I actually like this one because of the fact that it matches the white blood cell differentiation. So when you are going to learn about, for example, neutrophils, you're going to be able to see that you're going to have a myeloblast, or neutrophils, or white blood cells. After that one is going to be promyelocyte. Then it's going to be myelocyte. Then it's going to be metamyelocyte. Then it's going to be band neutrophil, then segmented neutrophil. This is the same idea. Rubri means red. Rubroblast is going to be the first one you're going to identify. Then you're going to have prorubrocyte. Then you're going to have rubrocyte. You're going to have metarubrocyte. Its pattern is going to match the white blood cells. That's the only advantage of it, and that's it. Either one, you should know, but again, you don't have to use all of them. Just be familiar what it means. And it's very easy because they are very similar in their names, in their root of the word. So, when we are going to go in and talk about these cells, there are some cells that we cannot identify. If anybody looks at under the microscope at these cells, they're not going to know. Are they going to become red blood cells or are they going to become white blood cells? What are they? At those stages, we are able, so the story is this. In 1960s, a group of scientists, they completely destroyed all the marrow cells of rats, mouse. We irradiated. They give radiation and they kill all the cells. Then they give the rats or mouse, I don't remember, I think it was mouse. They gave them bone marrow from healthy mouse. And they saw that after a week or two, the spleen shows this aggregate of these hematopoietic cells in the spleen, okay? And they followed those cells. And they say that those cells are going to become red blood cells. From there, they came up with this colony forming unit S. S stands for the spleen. That's where it's coming from. Okay? So this is going to be that cell that ultimately going to become one of these different type of cells in the case of the red blood cells. When it goes to the marrow, it's going to develop burst forming units, BFUs, burst forming units. What do they look like? A cluster of grapes, that's what they look like. You cannot identify them as anything. Nobody's going to be able to look at this on the microscope and tell you what they are. Okay, what they're going to become. But depending on the environmental cue, these burst forming units, which are going to have low erythropoietin, they're going to have very few EPO. They don't respond to EPO in this stage. There are other things they respond to. But if they differentiate to the next stage, we are going, and we're going to put E in here to indicate erythroid. They're going to be red blood cells. They're going to become CFUs again, E, erythroid. In this stage, one of the genes that are expressed is the gene for erythropoietin receptors. So these cells are going to be able to give a robust response to EPO. So erythropoietin would be able to increase their division, and it's going to make it to mature faster. Okay? We cannot identify these under the microscope at this stage, but the next stage after the CFU-E is going to be the normal blast. The pronormal blast, that stage that I showed you up here. That's going to be the next stage after the CFU-E. That you can look at it and you can identify it. Okay? All right. So there's a process. Remember, we are talking about big numbers you have to produce. You got to produce 1 million red blood cells per second. So there are going to be these immature cells, but as they are going to go ahead and gradually mature, there are going to be changes that's going to occur in these cells. Now, what are these changes? Because you will have to do this for the red blood cells, and you have to do this for white blood cells mostly. How would you be able, when you are looking at the microscope, especially if you are not trained, everything is going to look the same? Is that sometimes that, is it the time that you start to panic and start screaming for help and you say, I cannot do it? No. Find out what's the way. How would you people that are expert in this field are able to identify these cells? That's not complicated. It's very simple if you be able to keep that in your head. There are several factors that you need to look at. Number one, cell size. As the cell matures, becomes smaller. Is that hard for you to learn? As the cell gets mature, it gets smaller. It's very easy. Is there anybody there that's going to tell you what the size of the cell is? Sure, you got a lot of red blood cells there. Use those red blood cells as a reference. How big one cell is versus, you got mature red blood cells, how big they are. Another one is the shape of the chromatin in the nucleus. Is the chromatin going to be dispersed? Is the chromatin going to be like this? This is the chromatin that is actively making RNA and proteins. But as the time goes by, you will see that there is going to be condensation of the chromatin. That's going to be indicative of maturation of the red blood cells. So that's going to be one thing, the chromatin pattern. As it becomes more condensed, the cell becomes more mature. The size of the nucleus. The idea is that the size of the nucleus most of the time is going to become smaller, the cytoplasm is going to get bigger. So you have something we call nucleus to cytoplasm ratio. It's going to increase because nucleus to cytoplasm ratio is going to become decreased. It's going to get smaller. It's going to get smaller. Nucleus to cytoplasm ratio, N to C. As the cell matures, the nucleus is going to become smaller, the cytoplasm is going to get bigger, therefore the fraction is going to be smaller. It's going to become very small ratio, okay, as the cells mature. Nucleoli, not in every cell, but most red blood cells as well as the myeloid cells, nucleoli, which is going to be inside of the nucleus, they disappear. They disappear, okay, they disappear. Cytoplasm. I explained to you what the reasoning behind it is. The more the more ribosomal RNA you have in the cytoplasm, the bluer the color of the basophilic is bluish. The bluer the color of the cytoplasm is going to be. As the cell matures, all the proteins that were produced, they wanted to produce, they have done it. So gradually, you're going to see less and less basophilic or bluish color in the cytoplasm. These are the things that is going to enable you to identify cells. White blood cells, red blood cells, doesn't matter. These are the key that you have to pay attention. Pronormoblast. Look at the size. Look at the size, and I know that the screen, I don't know, maybe I'll put my glasses there, look at it. The nucleus chromatin is smooth. There is no condensation in this one. It's pronormoblast. Does anybody know what this is? You see there's a lighter area in cytoplasm? Golgi apparatus. That's the Golgi, doesn't get the stains. It's going to be like white spots around the nucleus. They got the nice Golgi apparatus. You don't see it in this image right now in this quality, but there are nucleoli there. There are small nucleoli there. The cell is large. You would be able to put 1, 2, 3, or 3.5 red blood cells inside of this cell. The ratio of the nucleus to the cytoplasm is going to be large because the nucleus is real big and the cytoplasm is small. All these things are going to point toward the identification of this cell as being the pronormoblast. Okay? Pronormoblast. Pronormoblast, oh, this is an important one, is able to divide, make more pronormoblast, or is able to go ahead and divide and allow the cells to mature to the next stage. That's going to be very important because pronormoblast is the one is going to have a lot of EPO receptors as well. So if you have lost a lot of blood, what you would be able to do, you would be able to increase the mitotic division of the pronormoblast. So instead of having one pronormoblast becoming 2 normoblasts, you would be able to have that normoblast to divide 10 times, and each one of those is going to become 2 normoblasts by itself. That's the way you're going to all of a sudden increase the production or decrease the production, by having these cells divide. Now the cell becomes smaller. How many cells are you going to be able to put inside? Red blood cells. 1, perhaps 2, maximum 2. So the size of the red cells is going to become smaller. Look at the nucleus to cytoplasm ratio, becoming smaller. Look at the condensation. Even with this bad quality, you can see the nucleus chromatin is condensed in this cell. This is the basophilic normoblast. The cytoplasm is still going to be very bluish. I would say a little bit even more bluer than the pronormoblast. But this is the example of the normoblast, the second stage. Things are going to keep happening. What's happening in here? The cell got even smaller in size. What's happening to the nucleus? Look at that nucleus. It's become more condensed. There are more condensations in the chromatin, as you can see. Something else is happening. What is it? The cytoplasm color is becoming pinkish. That's telling you that hemoglobin is adding up inside that cell. This is called polychromatophilic or polychromatic normoblast. So that's going to be the next stage. This is the last stage that a red blood cell progenitor can divide. At this stage, this cell can divide and make 2 polychromatic normoblasts, or it can divide and becomes mature other cell down the line. But this is the last stage a cell can divide. After this one, you're going to have the orthochromic normoblast and orthochromic. One orthochromic normoblast is going to give rise to 1 reticulocyte, 1 erythrocyte. At this stage, this can divide and make 2 of itself. They call it self-renewal, but it also can divide and differentiate in other cells. Okay? Now this is the late stage of orthochromic normoblast. This is the late stage. This is the time that this nucleus is ready to come out of the red blood cell. Usually it's going to be pushed to the periphery. Usually you're going to see the polychromasia, the bluish color of the red blood cells. And this cell, I would say within the next few hours, this cell is going to lose its nucleus and is going to get ready to come out of the bone marrow and get into circulation. Orthochromic. This cell cannot divide and make more of itself. It cannot self-renew, but it can divide and differentiate. It cannot divide anymore. It's just going to differentiate. It's going to differentiate into more mature cells. Now, you can see these reticulocytes in the bone marrow, or you can see that in the circulation. About 1 to 3% of your red blood cells are going to be reticulocytes. Okay? In this case, this is a right stain. What we are not calling these reticulocytes in here, what they are depicting is a description we call polychromasia. Okay? These cells are depicting polychromasia. When you're having polychromasia, it's very likely they are going to be reticulocytes. But that doesn't mean every reticulocyte is going to have polychromasia. If you catch the reticulocyte, the first, remember they're going to be in the circulation. How long? How long are they going to be in the circulation? Reticulocytes. About 48 hours. About 48 hours. If you catch these cells within first 24 hours, they're going to depict polychromation. Okay? If you catch them the second 24 hours, they're not going to have polychromation, but they are still going to be reticulocytes. Because reticulocytes is going to be based on the presence of ribosomal RNA in the cytoplasm. The bluish color, the polychromation that you see, is because of the presence of ribosomal RNA. Because that ribosome that was produced during this stage, still going to be some of it left in the cytoplasm during this stage. Still, they're going to be making hemoglobin in this stage. Yes, it's slowing down. It's stopping gradually. But remember, how long is the lifespan of a red blood cell? 120 days on average. 120 days. This cell has to function without a nucleus for 120 days. Think about it. If I remove your brain, can you survive 120 days? That's it, because that's going to be, the nucleus is going to be the brain of the cell. All the information is going to be there. So you've got to have everything ready. Okay? You've got to have everything in there, and everything is already, all the enzymes this cell needs for the 120 days, they're going to be in here. So that's what it is. You are going to have a lot of ribosomes continue producing the proteins that they are supposed to do the first 48 hours, but gradually those ribosomes are going to be broken down, and you're going to get into the mature red blood cell, which we call erythrocytes, and you can see that pinkish color, very nice central pallor, that's going to be in there. This discoid cell, shape of the cell is going to be very important. This is a normal red blood cell right here that you can see up here. Lifespan 120 days. How long does it take from that colony forming, from the burst forming unit BFU to get into the CFU, get into the normal blast, from the normal blast coming to the mature red blood cells? Usually every stage is going to take between 5 to 7 days. So it's going to be 5 to 7 days BFU to CFU, 5 to 7 days is going to be from the CFU to normal blast, pronormal blast, 7 days is going to be from the pronormal blast all the way down here. So from the time that you are going to start producing red blood cells until they actually get to the circulation is going to take about 21 days. So if you guys are deciding, you know, you're young, some of you might be able to take those challenges. You want to acclimate to the weather that you're going to climb up K2 or you want to climb up Mount Everest. You got to acclimate yourself to the height. How long is going to be minimum time? Is going to be 21 days. You cannot go there and stay there for a week in order to raise your hemoglobin, you know, your hematocrit. You got to, at least 21 days is going to take for these cells to get into circulation. Okay? So save your money because you have to stay there for a while. Now, the kinetics is a beautiful system. The way that you are able to maintain. See, guys, you guys got to get this concept in your head. Too much of anything is not going to be good. You have too little red blood cell, no good. That doesn't mean having a lot of red blood cells is going to be good. No, that's going to be a disease called polycythemia. Polycythemia is a disease in which you are going to have too many cells, especially too many red blood cells. Let me tell you one more thing in here. If I, on your exams and things like that, I ask you questions like this, I would expect you not exactly to understand what the disease is, but I expect you to understand at least something about this disease. What do you think is going to be characteristic of this disease? If you don't know it, break it down. Break it down to its component. What does poly mean? What does cyte mean? What is emia means? In blood. What is IA means? Pertaining to. Pertaining to a condition that you have a lot of cells in the blood. Okay? Polycythemia. It's bad. Why is it bad? Think about that poor heart of yours that has to pump the blood. Think about that think about this. You get you go to a movie and get what is this, fountain drinks of Coke, and you drink it, and think about You go to the gas station, you get a same fountain drink, a slushy. Which one is easier to drink? Not which one is more fun. Which one is easier to suck up the straw? The drink, the Coke is going to be easier than the slushy. Why? It's more condensed. It's less fluid. If you are having too many red blood cells, your heart has to push a slushy down your blood vessels. There's a limited amount of time, force that the heart is going to be able to generate to accommodate that. So it's not going to work. When you see somebody dies, recently, I mean, I have, once this person passed out in a gas station, they brought him to the ER and they called us to go in and draw blood. And I went there and I put the needle and he was unresponsive. He was unresponsive, he was blue completely. And I put the needle in his arm and I tried to pull on the syringe to get the blood, but the blood was not coming in. Pieces of blood would come in, like cottage cheese. Like cottage cheese would come out. He was dead because of the fact. I look at his hematocrit. His hematocrit was 75. A living person's heart cannot pump 75% hematocrit in their circulation. Dead person. Okay? So that was it. So the idea is that how we are able to control. We don't want too much, we don't want too little. The key is going to be in the kidney. Your kidneys are going to be the player in here. You got these group of cells inside of the kidney that are able to detect the amount of oxygen in your blood. So if tomorrow I decide to go, for example, to Machu Picchu in Peru, I go, that's I think about 13,000, elevation. I go there, what's going to happen? What is the concentration of oxygen at a higher elevation? Is it higher or lower? Lower. It's going to be lower, right? So what's going to happen here is that, first of all, I have to hyperventilate because my body cannot get enough oxygen. I have to breathe more to get more oxygen in because the oxygen concentration is less than out there. But what's going to happen? That lower oxygen level in the blood is going to go to the kidney. Kidney cells are going to detect that the oxygen level is low. They're going to generate this hormone called erythropoietin, for short. They call it EPO sometimes. It's a hormone. They're going to release it in the blood. The blood is going to take it everywhere, specifically to the bone marrow. And those stem cells are going to respond to erythropoietin. Remember that ball going down that valley? There are different valleys. Now that erythropoietin is going to push it this way, so that stem cell division is going to more incline toward production of red blood cells. What happens? You're going to increase your red blood cells. What's going to happen? When you increase your red blood cells, the capacity to carry oxygen is going to increase. Then you increase your oxygen in your blood, erythropoietin level is going to go down. When erythropoietin level is going to go down, that stem cell doesn't become red blood cell anymore. It's going to go become other things that need to be done. If there is no need for anything, it's going to go to apoptosis and it's going to die out. You don't want to produce too much because that's going to cause disease. Okay? So what's the secret? Why did Lance Armstrong join the Hall of Shame? What happened?
He would go up to higher elevation.
He was getting EPO. So if you and I are really competitive sportsmen or women, and we are trying to compete against each other, we need that edge. I need that edge to be able to beat you. Because we are equal. You give me a shot at erythropoietin, within a week I'm going to have my hematocrit increased by 2 points. If I'm supposed to run or bike 100 miles, I would be able to do a better job than you do because I have more cells to go in and supply the oxygen to my cells, to my muscle cells. It makes sense. That's why it's illegal if you're wondering, okay? Can we beat the system? Don't come and say that Dr. Nasser taught us how to cheat. I'm not telling you how to cheat. If you guys want to run a marathon, if you guys want to go ahead and get back in shape, if that's going to be someplace in Long Beach that you have to do a marathon, if you go ahead and train yourself for a month or two at higher elevation, for example, in Denver, for example. In Denver, when the time comes for to run the race, you come down to the lower elevation, you're going to have a higher hematocrit. You're going to have a higher hematocrit, you are going to have that extra red blood cell. But you didn't cheat it. You actually let the nature take its toll. Okay? Because by elevating your hematocrit, indicating that you are having more red blood cells, your capacity for oxygen carrying is going to increase. Okay? So that's the way that actually athletes do that. They train in higher elevation, they compete in lower elevation, which is fine. And again, EPO, we have the synthetic forms. Usually people who go through chemotherapy, we kill all of their hematopoietic cells in order to give them a transplant of the new cells. One of the things that we can do is that give these patients EPO in order to increase the red blood cell production. That's another thing. There are two concepts here, and these two concepts are very important. I cannot tell you how important these two concepts are. Even though I'm not going to talk too much about them, I want you to understand what I'm talking about. Okay? Then when we come to the anemia, you're going to be dreaming about these two concepts. What's going to happen here is extravascular hemolysis and intravascular hemolysis. See, folks, I told you that you have this turnaround in red blood cells. You're going to produce a lot of them. You're going to get rid of a lot of them. Getting rid of red blood cells. This is what we're talking about. We're not talking about producing them here. We're talking about how you're going to get rid of them. There are two ways. One is going to happen extravascularly. In a normal person, about 90% of the red blood cells that are going to be recycled, broken down, and removed from the circulation are going to be happening extravascularly. The name tells you what it is. It's not going to happen inside the red blood cells. It's going to happen in the spleen and liver. Primarily spleen, but liver has the capacity of doing something if it needs to do so. Okay? It's normal. The cell is old, comes into the spleen, macrophages are going to be able to detect it because of the environmental stress is going to make that red blood cells to become, change its shape, and it's going to be identified very quickly. The spleen is going to remove it. That red blood cell is going to be broken down and it's going to be recycled. We're going to talk about how details is going to happen, but that's called extravascular because it didn't happen inside of the red vessel. But if you really want to think about reality again, your heart is going to be able to pump the blood very strongly. Very strongly. If you cut my jugular artery, people in the back of the room are going to get red because of the fact there is such a pressure. I have actually seen it. I saw once, I was a kid, and I would say it was 35 years ago, and I saw somebody got shot in their head. And I'm serious. The blood went all the way to the door. It was just like a fountain for a short period of time. It was just crazy. It's just, I cannot get that image out of my head. But because of the blood pressure, because of the carotid artery pumping the blood to the head. So that's a very important thing. So that's going to be, there's a lot of blood pressure. So you got these big blood vessels. The word bifurcation means dividing into two branches. Trifurcation means dividing into three branches. Quadrifurcation means dividing into 4 branches. Let's say that simple case. You are going to have a blood vessel that's going to be divided into 2 branches. Blood is coming this direction. Sometimes this force is going to cause the red blood cell to hit this junction. That's going to damage the cell. That's going to destroy the cell. The hemoglobin is going to spill out. Intravascular hemolysis. That's about 10% of the red blood cells that are going to die. There is much more. I will tell you about the fine things because if you want to differentiate different types of anemia, you need to understand what happens in this case, what happens in this case. But since we're going to go ahead and cover it now in great detail later on, I'm going to stop at this point and answer any questions that you may have. Questions? Okay, because of the fact that we have 15 minutes and I have a bet with Meryl, I'm going to start another lecture. I got you. I see you guys in the laboratory or stop you. Take care.
What's your question? Just give me these.